Greetings, this is Dr. Doyle, and you are viewing Module 3 on exposure to toxic xenobiotics. As you may recall from Module 2, xenobiotics are natural and synthetic chemicals that are foreign to the human body. To name a few, this would include drugs, environmental pollutants, industrial solvents, and bacterial toxins. Exposure, by necessity, is a precedent of absorption and therefore is an important aspect of the study of toxicology. The identity and concentration of a toxoxenobiotic to which a person is exposed can be known or unknown. In the case of pharmaceutical or occupational toxic exposure, these factors are usually known or can be accurately estimated. In cases of environmental exposure, these are not initially known. It is the job of the toxicologist to identify soil, water, and air contaminants and to provide estimates of the exposure to human populations. From this information, procedures and legislative policies are developed to mitigate further toxic exposure. This type of work falls into the domain of regulatory toxicology, which we will discuss more at the end of this module. The Love Canal, a picture of which is shown here, is a toxic waste site that resulted in exposure to hundreds of inhabitants of Niagara Falls, New York in the 1960s and the 1970s. Please view both parts of the History Channel video on the Love Canal. You will find the links for these videos in the module folder. You might consider doing one of your discussion posts on the types of chemicals that leached from this site and what routes of exposure may have occurred in the inhabitants of this neighborhood. Many factors affect the toxicity of a xenobiotic. Some of these factors are related to the xenobiotic itself, some to the exposure setting, and some to the exposed individual's response. In this module, we will discuss the first three items on this list. Bioavailability will be discussed in the next three modules on xenobiotic distribution, and the last three items will be presented in the modules on toxicodynamics. The first two factors, dose and duration of exposure, are combined as the product of total exposure. This should not be confused with plasma concentration-time relationship, also known as the area under the curve, which will be discussed in the toxicokinetic modules. Nonetheless, it should be intuitive that the quantity of xenobiotic and the length of exposure time are directly proportional to toxicity. Increased duration of exposure could be due to prolonged continuous exposure to the xenobiotic, but more often is saltatory in nature, such as with chronic daily dosing of a drug. In either case, the plasma concentration will eventually come to a steady state level as shown in the diagram. What is less obvious is the effect of route of exposure on toxicity. Routes of exposure can include oral, dermal, respiratory, and parenteral. A general concept that you should know is that the route that produces the greatest xenobiotic plasma concentration is also the most toxic route of exposure. In general, the route producing the greatest toxicity is intravenous injection, which is followed in decreasing order by the respiratory, oral, and dermal routes. This series is correlated with the bioavailability of the xenobiotic by the various routes of exposure. If the xenobiotic molecule is volatile or can be readily aerosolized so that it can reach the lung alveoli, it is more readily absorbed by the numerous capillaries that surround the alveolus than if it must penetrate a thick epidermal layer to reach the dermal capillaries of the skin. However, the bioavailability is not always directly correlated with toxicity because additional factors may affect plasma concentration, such as a high rate of elimination or sequestration into a storage compartment. The concentration at the target of toxicity would provide a more relevant correlation. This is difficult to measure, but may be predicted based on physiologically based toxicokinetic models, which will be described in Module 6. The toxicodynamic interaction of the xenobiotic with the target of toxicity is the ultimate determinant of toxicity. This may be a rapid and direct interaction of a highly reactive xenobiotic at the site of exposure, such as with nitrogen mustard gases with the DNA and epidermal cells, or may be due to quantitatively minor toxic electrophilic metabolites that are often scavenged by antioxidants such as glutathione. An example of this would be acetaminophen-induced hepatotoxicity, which is most likely to occur in situations where hepatic glutathione levels are depleted. Even if the toxic metabolite interacts with its target causing transient cellular dysfunction, toxicity may be reversible by molecular repair or replacement, or cellular apoptosis and regeneration. This slide has a number of questions that the toxicologist should be asking when there is actual or potential exposure of a toxic xenobiotic to one or more people. To answer these questions, one must have knowledge of the chemistry of the xenobiotic and its metabolites, its absorption and distribution in the body, and the mechanism of action for its interaction with targets of toxicity. Let's say that you are a clinical toxicologist consulting with emergency department physicians who are seeing a case of acute poisoning after ingesting a full bottle of the thyroid replacement drug Synthroid. Because you are aware that the thyroid hormone is nonpolar and that the patient recently ingested it, you rapidly institute oral activated charcoal therapy to bind the unabsorbed drug. Thus, you have treated the patient by interrupting the first phase of intoxication, which is the exposure and absorption phase. Oftentimes, the poisoned patient does not present until significant quantities of the xenobiotic are absorbed. In these cases, you must use other strategies, such as interrupting the interaction of the xenobiotic or its toxic metabolites with the target. We will be discussing the mechanism of action for a variety of toxic xenobiotics throughout this course. It is very important for the clinical toxicologist to understand the mechanism of action because potential antidotes can be based upon counteracting this. In this example, the toxicologists and physicians would be concerned about the most life-threatening outcomes of hyperthyroidism, including ventricular tachycardia, and implement appropriate supportive treatment. Other questions here relate to regulatory toxicology. Safe or permissible levels of exposure must be determined because it is not possible to completely eliminate the possibility of exposure to these chemicals, especially those with economic importance. For those individuals who are most likely to experience exposure to higher concentrations or are more likely to have frequent exposures, such as in the occupational setting, appropriate protective measures must be put in place to safeguard this subpopulation. An example of this would be workers who are involved with some industrial activities are exposed to volatile halogenated hydrocarbon solvents. These workers must have appropriate personal respiratory protective equipment, ventilation systems, and air monitoring of the work area. Exposure is the first step in a multi-step process, ultimately resulting in interaction of the xenobiotic with its target of toxicity. We will be returning to this diagram in the next several weeks as we look at the subsequent steps of absorption, metabolism, elimination, and target interactions. In the Renaissance era, it was common for educated people to adopt a Latin nickname. This Swiss physician, and I will not even try to pronounce his true name, called himself Paracelsus, which means beyond Celsus. Celsus was a Roman author who lived from about 25 BC to 50 AD and wrote De Medicina, which cataloged medical information on diet, anatomy, pharmacy, surgery, and other topics. Paracelsus is probably best known for first stating a well-known axiom of toxicology, which can be paraphrased as, "The dose makes the poison," meaning that anything can be toxic if it enters the body at a high enough dose. In addition to the quote shown here, Paracelsus also made the observation that the right dose differentiates a poison from a remedy. This, of course, is the basis for the pharmacological effect of numerous drugs, which are toxic if the therapeutic dose is greatly exceeded. A dichotomy of beneficial and adverse effects that is not related to differences in dose may also be observed for many non-drug xenobiotics, such as pesticides, which are more toxic to insects than to humans because of species-specific differences in xenobiotic metabolism. This table illustrates what Paracelsus had said, which is that any chemical can be toxic if it is administered at a sufficiently high dose. We know that excessive consumption of ethanol can lead to death, but this is usually a result of automobile accidents. This compound and others have been tested for direct lethality in animals, usually rodents. For reasons that we will discuss in the next module, the dose causing lethality is usually the dose that results in the death of 50% of the animals tested at that dose, called the LD50. We can see from the table that there is a wide range in potency for the various xenobiotics, approximately 100 million-fold range shown for these chemicals. Even though the topic of this module is exposure, which occurs at surfaces exposed to the environment, I am going to use this diagram, which illustrates the mechanisms for molecular movement across the endothelial membrane barrier and capillaries. It does not matter if we are talking about the movement of molecules across vascular endothelial cells, intestinal enterocytes, epidermal keratinocytes, or the cholangiocytes lining bile ducts, because they are all epithelial cells with similar mechanisms of transport. The first mechanism of transport occurs through the spaces between adjacent cells through which the molecules can move by paracellular flow. Restriction of paracellular flow occurs when the epithelial cells are closely opposed. This effect is greatest when there are more tight junctions than adherens junctions, such as in the cerebral capillaries forming the blood-brain barrier. Most xenobiotics that leave the circulation are nonpolar and are passively able to diffuse through the phospholipid bilayer membranes of the capillary endothelial cells. In some cases, polar xenobiotics are able to utilize the same protein channels or transporters that mediate facilitated active transport of nutrients such as glucose and amino acids. Active transporters are also involved in transporting some xenobiotics from the extracellular tissues back into the bloodstream. For example, P-glycoprotein multidrug resistance protein 1 exporter minimizes doxorubicin-induced cardiotoxicity by pumping the drug back into the coronary circulation, much like a bilge pump prevents a ship with a leaky hull from sinking. Unfortunately, this exporter works against a concentration gradient and requires ATP. Doxorubicin causes mitochondrial injury and thus results in ATP depletion and decreased activity of all active transporters. So, doxorubicin, a nonpolar molecule, readily diffuses into the cardiomyocyte and accumulates because it is no longer actively transported out of the cell. Cellular uptake of a xenobiotic can also occur by endocytosis, when the molecule binds a cell surface receptor and the entire complex is invaginated within a pinched-off vesicle derived from the plasma membrane. Non-receptor-mediated cellular uptake can also occur by the process of pinocytosis, which is bulk phase absorption of extracellular fluid into intracellular vesicles. Passive diffusion through phospholipid plasma membranes is the major mechanism for xenobiotic absorption and transfer between body compartments. Therefore, it is important for the toxicologist to assess this characteristic in potential toxic compounds. A simple in vitro test that examines the relative solubility of a xenobiotic in octanol and water is routinely used for this assessment. Octanol is an ideal solvent for determining plasma membrane diffusion because the carbon to oxygen ratio is very similar to that found in these membrane lipids. Most xenobiotic molecules are very soluble in octanol, so the main determinant in fractionation of the molecule in this two-phase system is the solubility of the xenobiotic in water. The concentration of the xenobiotic in the octanol phase is divided by the concentration in the water phase to yield a partition coefficient called the POW. The POW is expressed as a logarithm, so tetrachlorodibenzodioxin, a fossil fuel combustion end product, has a 10 million-fold greater solubility for octanol than for water, whereas paraquat, a herbicide, has about 100,000-fold greater solubility in water than in octanol. As we will see next week, the octanol water permeability coefficient is a useful parameter that can be used to calculate passive diffusion in physiology-based toxicokinetic models. We will now discuss the three major routes of exposure for toxic xenobiotics. The first of these is oral exposure. This is the typical route of exposure for drug-induced toxicity, but it also is a route for unintentional exposure through contaminated foods and water. I will make the point again that nonpolar lipophilic xenobiotics are most readily absorbed, not only in the digestive tract, but also via other routes of exposure. This is a very important concept. Diffusion through plasma membranes is also greater for smaller xenobiotics. Within the small intestine, some charged and polar xenobiotics are absorbed, such as cadmium, because they can cross the phospholipid membrane barrier by facilitated or active transport. Some organic compounds can be polar if they carry a charge, such as organic acids or bases. Absorption of an organic acid, such as salicylic acid, is optimal when it is uncharged. As shown in the figure, this occurs following ingestion when benzoic acid is protonated in the stomach, where gastric acid secretions are at a pH which are lower than the pK of benzoic acid. The opposite occurs for the organic base aniline. Aniline loses its positive charge when it releases a proton within the slightly alkaline lumen of the small intestine. Another factor which influences oral absorption is the amount of time that the xenobiotic has contact with the absorptive surface. If gastric emptying or intestinal motility is increased, such as by administering erythromycin or a laxative respectively, one would find a decrease in absorption. As you can see, by understanding the mechanisms of xenobiotic toxicokinetics and toxicodynamics, one can develop rational interventional strategies to treat the poisoned patient. Exposure by inhalation is likely with xenobiotics that are gases, volatile liquids, or can be aerosolized as fine particles. This route of exposure can result in high bioavailability of the inhaled xenobiotic because of the extremely small diffusion distance between the alveolar epithelial surface and the lumen of the extensive perialveolar capillary network. The site of absorption is mainly a function of the physical and chemical properties of the inhaled xenobiotic. Polar compounds tend to be trapped in the moist mucus layers of the surface of the nasal passages, oropharynx, and trachea, as do particulates with a diameter of 5 micrometers or greater. Smaller particles, having diameters between 1 and 5 micrometers, impact in the mucus layer of the lower conductive airways such as the primary, secondary, and terminal bronchioles. Nonpolar gases and ultrafine particles with a diameter less than 1 micrometer travel all the way to the alveoli. Some of the ultrafine particulates may become phagocytized by alveolar macrophages, which may then migrate into the lymphatic vessels, or they may migrate toward the terminal bronchioles. Macrophages and xenobiotics trapped in the mucus layer may be swept superiorly along the surface of the ciliated epithelium until they reach the larynx, where they pass into the digestive system via the esophagus. Whether absorption occurs in the alveoli or in the digestive tract, respiratory exposure can lead to distribution of the toxic xenobiotic throughout the circulatory system, producing toxicity in other organs. Interestingly, respiratory exposure is a route through which a xenobiotic may gain access to the nervous system, as shown in the purple arrows, especially the cranial nerves that innervate the respiratory epithelium in the head and neck regions. This would be an example of inhalation toxicity, which is defined as toxicity in a non-respiratory organ that results from exposure through the respiratory system. In contrast, respiratory toxicity is defined as toxicity to the respiratory organs, such as the lungs. This may or may not result from exposure through the inhalation route. An example would be the pulmonary edema and the fibrosis produced by the herbicide paraquat following ingestion, but not by inhalation. Most environmental exposures occur through the cutaneous route. This includes exposures to toxins, pesticides, herbicides, and solvents in the home and workplace. Fortunately, the skin provides a more protective barrier to xenobiotic absorption than do the absorptive surfaces of the oral and respiratory routes. The principal barrier is the most superficial layer of the epidermis, called the stratum corneum. This hydrophobic layer is composed of keratin protein and sphingolipids. Any loss of this superficial barrier, such as by abrasion or extraction of lipids with organic solvents, results in greater permeability. Non-polar xenobiotics easily move through the stratum corneum by simple diffusion until they encounter the more hydrophilic basal layers of the epidermis and dermis. Polar xenobiotics can diffuse through the stratum corneum in areas where hydrophilic accessory structures are present, such as sweat glands and hair follicles. Absorption of polar xenobiotics is increased when the water content of the stratum corneum is increased. Absorption of xenobiotics is inversely proportional to the thickness of the epidermis, especially the stratum corneum. this layer can be up to 10 times thicker in the palm of the hand and sole of the feet as compared to the skin on the back. Cutaneous absorption is also increased with increased dermal blood flow, as during exercise or when the core body temperature is elevated. Exposure to xenobiotics is an inevitable occurrence in life. We are exposed to drugs which have potential benefits towards health conditions that we suffer. We are exposed to chemicals in the workplace and at home which are of economic or public health value to us, such as pesticides. We are even exposed to toxic agents that have no potential benefits, such as the aromatic amines that are generated when we barbecue a steak on the grill. It is not possible or even desirable to eliminate all xenobiotic toxicants from the environment, but United States public health agencies endeavor to minimize this exposure through regulatory processes. The diagram shown here illustrates the general regulatory process that applies to various agencies, including the Food and Drug Administration, the Environmental Protection Agency, the Occupational Safety and Health Administration, and the Consumer Product Safety Commission. This is a risk assessment and management system that initially requires the collection of data on chemical risk, which is the combined effect of the potential toxicity and possibility of exposure. The toxicity component is related to the toxicokinetic and toxicodynamic properties of the xenobiotic, and the exposure factor includes external dose and absorption. The data may include human epidemiological studies, but for ethical reasons it is mostly derived from controlled in vitro and animal studies with appropriate extrapolations to humans. We will discuss some of these types of assessments in greater detail throughout the course. A major part of the risk management process is to have a well-developed dose-response assessment for the toxicity of the xenobiotic. The dose-response relationship will be discussed in greater detail in Module 16. Of course, the maximal exposure level for every xenobiotic is different based upon its specific dose-response relationship. Furthermore, the duration over which the maximal exposure threshold is applied is dependent upon the type of toxic effect that is produced. The agencies responsible for setting exposure limits are the National Institute of Occupational Safety and Health, the American Conference of Government Industrial Hygienists, and the Occupational Safety and Health Administration. Only OSHA-mandated exposure limit values are enforceable by law. Some xenobiotics have short-term exposure threshold values, whereas a potential genotoxic carcinogen would generally only have a lifetime maximal exposure limit applied to it because mutagenic effects are considered cumulative. The exposure duration limit values include the 8-hour per day, 40-hour per week time-weighted average, or TWA, the ceiling value, or CV, which must not be exceeded for any amount of time, and the 15-minute short-term exposure limit, or STL, which must not occur more than 4 times in one day. You have now completed Module 3. Please test your comprehension of the material by taking a short quiz in the Module 3 folder.